Good afternoon and welcome to Virtual Face-to-Face with President Bruce Jarrell. I'm Alex Lakowski, Executive Director of Media Relations. After 18 months of pandemic, UMB is mostly back on campus. But for many of us, it's not exactly what we expected. Just 4 months ago, 3 million Americans were being vaccinated every day, prompting President Biden to predict what he called a summer of joy and prompting higher education to plan full-scale returns in the fall. And why not? The vaccines work wonderfully, particularly at preventing serious illness. And here at UMB, with a vaccine mandate in place, the vaccination rate in our community has climbed to about 95%. And we've done a pretty good job of adapting to changing safety protocols involving masks, social distancing, and the like. But of course, as we adapt to COVID, as viruses like to do, is adapting to us. UMMS CEO Dr. Mohan Suntha recently told staff the prevalence of the very highly contagious Delta variant in Maryland went from just 3% of cases in May to 93% in August. But also growing concern about another variant, a few letters lower in the Greek alphabet, Mu. The WHO has added it to its variants of interest watch list last week, saying it appears to be resistant to the antibodies produced by natural immunity, current vaccines, and monoclonal antibody treatments. It's been reported in every state but Nebraska, but so far only in very small numbers. Now, getting back to the Delta variant, the number of cases there has risen to very high levels, with new hospitalizations and deaths occurring almost exclusively among the unvaccinated. The American Academy of Pediatrics says the number of children testing positive for COVID jumped exponentially between August 5th and September 2nd, with more than 250,000 added just last week. So all over the country, safety protocols are tightening in response. In a letter to the UMB community exactly 1 week ago, President Jarrell announced the return of our indoor face covering policy. Later today, President Biden, president of a little bit larger institution, will deliver a speech outlining an aggressive new plan that will, among other things, require most federal employees and government contractors to be vaccinated. At around the same time, the LA Unified School District, the nation's second largest, is expected today to approve a requirement that all 600,000 of its students that are eligible for that to be vaccinated by the end of the calendar year. Now, the surge of Delta variant cases has also convinced many of the vaccine hesitant to finally get the jab. Governor Hogan announced that about 81.5% of all Maryland adults have now received at least one dose. And among seniors, it's more than 95%. At a press conference yesterday, the governor announced that all Marylanders over 65 living in congregate care facilities like nursing homes are immediately eligible for a booster shot. Stricter safety and vaccine rules are also helping things get back to something that resembles normalcy all around the country. Fans attending the Ravens game Monday night in Las Vegas can attend without a mask because they will all be vaccinated. Supreme Court's coming back in October for the first time in almost 2 years to deliberate in person. Even the Macy's Thanksgiving Parade is coming back live with all participants vaccinated and masked. Now, not everything that confronts us here is medical. Fear and misinformation continue to drive many of us to desperation. We're just getting past headlines about thousands of Americans clearing store shelves of the anti-parasitic drug ivermectin, which has no proven ability to treat COVID-19. It's used in humans to treat severe cases of things like scabies and lice, and most often used to deworm livestock, prompting this uncharacteristic tweet from the FDA: "You are not a horse, you are not a cow. Seriously, y'all, stop it." And there is one more thing. As anyone who's worked all day in a face mask or attended 10 Zoom meetings in a day at their kitchen table can tell you, we're not just anxious about COVID, we're tired of it. We're tired of being separated in large ways and small from friends and colleagues, tired of having our heads filled with restrictions and changes, tired of stressing over masks, boosters, and breakout infections. And of course, because of all this stress, we're just tired. So add exhaustion, anxiety, even depression to the medical issues surrounding COVID, and we've got a lot for our guests to break down for us today. Joining Dr. Jarrell to do that are Jim Campbell from our Center for Vaccine Development and Global Health. He's also a professor of pediatrics and a principal investigator in a Moderna vaccine trial for children ages 6 months to 11 years and teenagers in the Novavax trial. We're also joined by Cassandra Moon, staff psychologist and outreach director at the UMB Student Counseling Center. Welcome to you both. I want to remind everyone that this program is being recorded and will be posted on the UMB homepage. And a little later in the program, you will have a chance to ask questions. Please write them in the chat area. When the time comes, we'll call on you by name to ask your question. If you'd rather remain anonymous, that's okay. Just be sure to let me know that. With all that out of the way, let me introduce to you our host back after the summer, Dr. Bruce Jarrell.
Thank you, Alex, and for all of you out there. I know it's a great pleasure for you to be back. The summer's over, the fall's here. It should be business as usual, but of course it's not business as usual. We were all hoping so, but that's not the way it's going right now. We've got still a lot to learn about this virus. It seems to have its own ability to fool us at every corner. So a lot to learn, and hopefully we'll learn a little bit more about it today. I'd like to welcome our two guests, Dr. Campbell and Dr. Moon. Thank you very much for joining us. And maybe what I'd do is start out with Dr. Campbell and then Dr. Moon to just tell us briefly a little bit about where your focus is. And I know for Dr. Campbell, it's in your pediatric vaccine trial. And I know people are very anxious to hear about that. So could you fill us in for a couple of minutes on what's going on there, where things stand, where do you see it headed?
Sure, thanks, Dr. Jarrell. So we are participating here at the University of Maryland School of Medicine, two pediatric COVID vaccine trials. One is for the product made by the company Novavax, and that is enrolling or has enrolled teenagers, so 12 to 17-year-olds. And where that stands is it's fully enrolled. All of the teenagers were assigned at the beginning to either get vaccine or placebo. And then a few months later, they were crossed over, as we say, in a double-blind fashion. So if you got vaccine to start, then you got placebo later. And if you got placebo to start, you got vaccine later. So now they're all fully vaccinated. They just don't know if they got the vaccine at the beginning of the trial or just in the last couple of weeks when we did the crossover. So we don't have any results for it yet.
We have a different kind of bug in the system, I think. Maybe we'll wait for Jim to get reconnected.
Sorry, I'm having some bandwidth problems.
Ah, there you are.
Okay. Our other trial is Moderna's vaccine, and this trial is enrolling children 6 months to 11 years old in different age strata. And currently what we're, the children that we're vaccinating are 6 years to 11 years, and they are receiving half the adult dose or placebo, and then we're following them for immune responses and safety. And that also is fully enrolled, a little over 4,000 children in the United States, and we enrolled here and at our site in Frederick. And we're continuing, they're about to get their second, some of them just started, but they're getting their second vaccinations now in that series. So we're expecting that age range, 6 to 11 or 5 to 11, to hopefully to have the Pfizer vaccine available in the next couple of months, and then the Moderna a few months after that, as long as everything goes well with the review by the FDA.
Thank you, Dr. Campbell. But we'll get back to you, and I want to remind the audience that we are obviously receptive to your questions, and Alex will coordinate that. But please, good questions here are what make this work. So Dr. Moon, tell us a little bit about what you do and what you're seeing that's changed over the last 18 months and how you've responded to it.
Hi, so I'm Dr. Cassie Moon, pronouns she, her, hers, and I'm staff psychologist and the outreach director at the Student Counseling Center. Over the past 18 months, we've seen a lot of adjustment from the students. And I'll be honest, and I think for both the students and for staff and faculty, it's been a really hard year. We're already deciding to kind of define this as another generational trauma that all of us have shared and had to go through. So I more just want to bring that to everyone's attention so we can work on being aware of how you're feeling and remembering to being kind to yourself and to others, because it hasn't fully ended yet, as we just heard from Alex.
And you're largely, are you largely giving counseling through remote mechanisms, or how much in person, and what's the mask do to those kinds of interactions?
Because of the mask mandate, we are doing the majority of our work via telehealth. The reason being is, while of course I feel like I would be most effective in person without a mask, all of the counselors here have been certified as telehealth clinicians. And so I would say we're probably 90 to 95% as effective as we would be. The issue is in person when we wear masks, it drops the effectiveness a lot. People have a harder time trusting and being able to relate with their counselor when the counselor wears a mask. And I have a harder time reading facial expressions and hearing tone. And those are critical in therapy. So while we are here, we're trying to do as much telehealth as possible because we feel like we are more effective rather than doing in person with masks. We also want to keep people safe. If they're coming into our office and they're stressed, we know their immune system's not going to be quite as strong. So we want them to be as safe as possible.
Gotcha, thanks. Dr. Campbell, I know you see the world's literature, and I guess my question would be, beside the kinds of trials that you're involved in the US, what data are there from other countries related to pediatric trials, whether they're anecdotes or significant research efforts? And any data on that?
I mean, in terms of pediatric vaccines, I
Yes.
think we're about the furthest along. There's not a lot of additional experience outside. There's experience, but there's not a lot really to report like that as we can for some other parts of COVID. We do have some data from outside, like in the UK, but it's not really going to be all that helpful for us in order to get these vaccines ready for evaluation for children. I mean, we and others have been pushing to try to get the vaccine trials started earlier than they started, and now for them to get reviewed, the data to get reviewed more quickly. There's a fair amount of pressure now, I think, on the regulators to see what they can do to make this process move more quickly, especially with Delta around. The president of the American Academy of Pediatrics wrote a letter stating, just how important it would be for review to occur quickly. Right now, the FDA is requiring 6 months worth of complete data in each of the age strata before they'll entertain reviewing the pediatric vaccine data. It was only 2 months for the adult data. And pediatricians across the country and some people in Congress now are trying to say, well, should we reconsider that and review it more quickly, given this huge surge, as Alex mentioned, of hospitalizations and cases among children. I mean, a quarter of all the cases now are in children. There are some pediatric hospitals in places where Delta is surging more than here that are full, their ICUs are full. So we need additional tools and vaccine. We know these vaccines work really well. We just need to have the data reviewed so that we can determine whether or not they can be used safely in kids.
Well, why all the precaution? Why are you so much more cautious with children in these trials than adults? What's the thinking behind that?
I think it's a good, overall, it's a very good thing that we're very cautious with any medication and any vaccine in children, because especially vaccines, because they're used prophylactically. So once they're licensed and recommended, typically the expectation is that all children, so millions and millions, will receive the product, and they start off healthy, and you're trying to prevent something. So your bar for safety has to be very high. And we, of course, in the pediatric world and as parents, all agree that we want to have watchdogs and want to have people overseeing, making sure that that's the case, that we're having, that we're not licensing things until we're sure that they're safe and effective. Given the experience that we have right now with these vaccines and the numbers of adults that have been vaccinated and the just phenomenal protection that people are getting and the great safety record, and now thousands of children having received the vaccines, we think that the reviews can occur more quickly, not trying to cut any corners, but trying to come up with, what's the rationale behind waiting 6 months? We haven't ever had a vaccine, pediatric or adult, where 6 months after the vaccine, you discover some unexpected problem. So it would be brand new. If that was the case, it would be a brand new whatever that is that we're waiting the 6 months for would be something we've never seen before with vaccines. So I think that's the main reason why there's some pushback, is to say, sure, 2 months or 3 months, make sure we don't see anything in that period, but not 6 months, because kids are, they're in ICUs. Kids who are dying. We've had more than 500 kids die in the United States. So if we have something that can protect them, we want to make sure that it gets reviewed as quickly as possible.
But you must have a figure in your mind for how many kids die of RSV and flu each year. And I'm not trying to discount 500 deaths. Of course, it's highly significant. How does this death number compare with what you would see in a flu season?
It's considerably higher than any reported pediatric flu season death since we've been recording it for 16 years. Before that, we knew some numbers, but it hasn't been like a reportable number except for the last 15 or 16 years. And it's higher than RSV every year. So it's currently, COVID in kids death rate is currently about the 9th or 10th most common all-cause death for children in the United States. So it's much less severe than in adults, but when you compare it to other pediatric problems, it's a severe problem. So, it's greater than any other vaccine preventable disease that we have now. There were ones years and years ago that were more mortal than this, but none of the ones that are, we currently vaccinate against, or any of the other ones that we have like in the pipeline to vaccinate against, have that much mortality for children.
Well, thank you. Reminding the audience that get your questions in here, because we'll turn to those in just a few minutes. Dr. Moon, one of the things you told me earlier was that I had to learn to be nicer to myself than usual during these times. I don't think you were pointing a finger at me. I think it was a general commentary, as well as nice to other people. Could you just elaborate on that a little bit more about what are the kinds of things that you, besides just the expectation, there must be other things that you got in mind there?
So the way I tend to describe it to students is, this isn't real, but just in metaphorical sense. You have your brain, and inside of your brain is this little, we'll call it a ball of anxiety called COVID. That ball of anxiety is just sitting there, and it kind of slows everything down a little bit. And so you're doing your best to work through it, but that ball of anxiety, and that's just the COVID anxiety. If you're a grad student, a med student, a law student, you also have more little balls in there. But that ball's a pretty big ball because it's, like I said, a generational trauma, and it sort of slows everything down a little bit. So you feel like you need to work a little bit harder. You feel like your motivation's a little lower. You feel like your sleep's impacted a bit. Your mood's lower. Just everything feels a bit more foggy is the way I describe it. And because of that, if you try and set yourself at the expectations where you were, let's say 2019, you're setting yourself up for fail a little bit because you have that. Now, some people are performing the same, that's true, but a lot of people aren't. And when I say be kind to yourself, I mean, that's okay. That's okay if you're not performing as well. I wouldn't expect you to be honest. And I don't want you to have to expect yourself either. Does that help answer your question a little bit? I think you're muted.
I think so. And we've also, of course, got our students going back to the classroom now. We're talking about full classrooms, and for the audience, we anticipate early next week we're going to require KN95 masks for our students in the classroom. That'll be an uptick in terms of the protection we're putting in place. So what kinds of problems or issues or stress or anxiety do you anticipate for the students returning to the classroom? What are the kinds of things we could expect coming out of that?
So I know some students are super, super excited to go back. They're ready, they learn much better in person. But we also have to be honest that many students have done significantly better learning remotely. And so for them, it is going to be a pretty big adjustment. Plus with the masks, they can't like eat their food or drink water while they're sitting there. So it is going to be a big adjustment. We've also noticed a significant increase in social anxiety, people learning how to talk in person again. So I would encourage everyone who's listening to this to be, when you can, when possible, be incredibly flexible with in-person requirements, be willing to adjust when people need it. But I think for a lot of students who did learn better remotely, it is going to be a hard adjustment on them.
And probably for the professors who are teaching as well, huh?
Yeah, for them as well, yes.
Yeah, we had some in-person things today. We celebrated the vaccination clinic that we stood up. We had a welcome back to campus event. We did a ribbon cutting on your new center, which
That's true, you did.
Here in a minute. And it felt so funny to actually see people talking in person than it did to see them talking on the screen.
Yeah.
There was a moment in one of the discussions where the person actually talking got muted and the screen was talking for her. And I felt really comfortable when that was happening, even though that wasn't what was supposed to be happening. So it's funny how we've sort of changed our way of thinking here. So, Dr. Campbell, another thing that's been hot on the list is booster shots. And I guess this is not for kids, but for adults for the moment. What's sort of your take on all of that?
Yeah, it's a complicated complicated field, if you will. So currently, anyone who has certain types of immune compromise, so whose immune systems may not have allowed them to respond as others would to the vaccine, are now authorized to get a third shot. It's not truly a booster for them. It's more of a third shot because the first two know from studies that have recently been done that people with immune compromise tend not to respond that well to two, but respond quite a bit better when they get a third. And we also know that there were considerably more immune compromised people who went on to have infection after vaccine than immunocompetent people. So those two things combined led to the companies and the regulators to say that we should give a third shot. But what you're asking about, I think, really is, should all of us and should the immunocompetent, should the general population who's been vaccinated get a booster? And what boosters are, as you probably know from other vaccines that we get, is you get like a primary series that primes your immune system, gets you protected early, but then leads to memory. You have this memory that you're kind of matures over time. And if you wait enough time, like 6 months or a year, and then you get a single additional shot, you get this very high amount, typically very high amount of antibody. It's why, like little kids, they get all these shots when they're babies, and then when they start kindergarten, they get another one that boosts them way up for a very long time after that. So there's evidence that getting a third shot, getting a boost 6-8 months later definitely boosts, definitely gives you higher antibody levels. And it looks like it's safe, that there's no unexpected, at least short term, right? No unexpected problems with giving that boost. But those data don't necessarily mean that we all should get boosted, because essentially there are no vaccines where if you wait 6 or 8 months and then you revaccinate people, that they won't get a boost and they won't, and it won't be safe. So the question is it necessary, and will it be helpful? Will it reduce, Delta cases? Will it protect you more? It could be that we're all, even though, yes, you get a boost, it could be that the waning antibodies that you have are not that important. In other words, that you're still protected, that you're still way above the threshold of protection. These are the sorts of things that it's important for experts to review all of the data in order to be able to make those decisions. So on the 17th, so 8 days from now, the Food and Drug Administration has an independent body called VRBPAC, and that group of experts in vaccines are reviewing all the data on boosters to inform the FDA to try to decide, should we give boosters or not to immunocompetent people? The most convincing evidence really so far has been in Israel, where they started a program to immunize, to give a booster. And it does look like, at least in this preprint from them, that those who got the booster had reduced infection rates compared to those who had not gotten the booster yet, at least. If I have to predict, they're only going to recommend boosters for Pfizer vaccine to start, because I think the data are not going to be as robust or available yet for the other vaccines. And they'll probably do it in a similar fashion to what was done when we first started vaccinating to start, and that is in phases. And say, like, who are the most vulnerable and will benefit the most from a third shot? And those are going to be like people living in nursing homes and assisted living facilities and that sort of thing, and elderly and others who are at the highest risk, and also tend to have what we call immunosenescence, meaning that they don't respond as well to vaccines anyway. They may not be truly immunocompromised, but not respond as well and have higher risk. So it may be that there's this phased in booster shot program across the US. And I think we should wait until next week when we hear what the review is at VRPAC, where all those data will be presented. But we should be prepared that there probably will be boosters. It's just we don't want to jump the gun until we have all the data and understand the data.
Right, got it. Alex, I hear we got some questions. So
We do.
Will.
All right, they're coming in. First, this anonymous question. I'd like to know what the guests think about the risks facing parents with children under the vaccine age and too young to wear masks. Being required to work 4 to 5 days with a child at home feels shockingly risky, she says.
Yeah, okay, maybe I'll start. So as most people probably listening know, children, even though I've just told you how it can be very bad in children, for the most part, it's not. So most children who get infected with this virus either are asymptomatic, like you don't even know that they had the infection, or have a mild infection, and that is like cold type symptoms. So the vast majority of children do not go on to have severe disease, but unfortunately some do. And yes, there is risk, whether they're at home or whether they're in school or in daycare. There's going to be risk as long as there's community spread. And the best that we can do until we have vaccines for kids is to do all the things we've been talking about for a very long time. And that is vaccinate everyone around them. So anyone they're in contact with who is eligible to get vaccinated, they should. We call that cocooning, and it does help. We know that in states that have the highest vaccination rates, they have the lowest pediatric hospitalization rates. And those aren't because the kids are getting vaccinated, it's because the adults are getting vaccinated. So it's vaccinate everyone around them, and then all the other things we know help. And that is, masking, hand washing, social distancing, being outdoors whenever possible. All of those things are helpful. And in public health, we talk about the Swiss cheese model, which is nothing's going to be 100%, but when you put multiple layers to protect you, you keep reducing your risk, you can have, a reasonable amount of risk reduction. We're never going to get to zero risk for any of these, any infection really, but we can certainly reduce the risk by putting all those things in place.
Dr. Moon, anything to add to that?
Not particularly. It's just I know a few of the student parents or even other faculty and staff who are trying to manage. And I think there's also a bit of a fear of the public schools needing to go virtual again because of outbreaks. And so them wondering, how am I also going to manage needing to be in person for classes or work when we all know childcare is incredibly expensive. So that's a common another stress I tend to hear about from students who are also parents.
Gotcha. Alex?
All right, we have more questions, but just a quick point of clarification. Someone writes, I just heard Dr. Moon say students could not drink in class, but I understood from the August 23rd change The drinking was allowed as long as the mask went back on immediately after. Has that advice changed since August 23rd?
I don't believe it's changed. The idea was you could briefly put a straw or something in your mouth, have a sip, and then put your mask back on. So that was permitted.
I apologize. I think it just said water, but I apologize. You're right. I
No,
forgot
just-
that was
just,
still
just, that's just a quick clarification. There's no problem.
Technical detail.
I want to bring in Glenn Bedell, who is asking a question that came up in the during the summer. We had a Q&A, and there was a question about some patients, especially young men, developing myocarditis and pericarditis. Glenn, go ahead and ask your question.
Yeah, thank you very much. So my question was about pediatric patients developing myocarditis and when they were vaccinated. And has this really been investigated and understood, or is this still a concern? And yeah, so if you could just respond to that.
Yeah, no, that's a really important question, and it's on the minds of parents and pediatricians and public health officials, and it's being followed very carefully. So right now, the only vaccine that is authorized and or licensed for anyone who's considered a child is the Pfizer vaccine. So emergency use authorization if you're 12 to 15, and then licensed for 16 and 17-year-olds. So we have millions of kids that age who have received that vaccine. And there have been cases of myocarditis, meaning inflammation of the heart muscle and some of the lining of the heart, that's pericarditis, among kids who have received that vaccine. And it looks like in young adults and in older teenagers, especially more boys or young men than girls or young women, and especially after the second dose, like in the week after the second dose, that the rate of that problem is higher than what most people think would be expected in the general population in that short of a period of time. So we think it's a real association, but very rare. It's difficult to get at the exact number of just how very rare. I mean, we know how many cases have been reported, but knowing how much that is over the baseline is a difficult number to come by. But it was not seen in any of the trials, and that's because the trials were not big enough to see it. It wasn't until you got to millions of people getting the vaccine that we could see that. And so it's on the order of probably single digits per million vaccinated, or maybe single digits per 100,000 vaccinated. So we won't know the exact number until a long time from now. But if you compare that to myocarditis and pericarditis, especially myocarditis, among people who have COVID-19 disease, it's minuscule. So if it protects all of those other people from getting COVID, then it's reducing the overall number of people who get myocarditis and pericarditis. And most of the vaccine-associated cases have been quite mild. Typically just a day or two in the hospital, usually only getting NSAIDs, meaning like ibuprofen as their treatment, and not going on. I mean, we in pediatric ID sometimes see really bad myocarditis after viral infections, simple viral infections, some of which go on to need like ventricular assist devices, these things that will help to squeeze your heart because your heart can't squeeze anymore, or even heart transplants. That's not what we're seeing with vaccine associated. These tend to be quite mild. So I think most people think when you weigh the balance of vaccine versus COVID, yes, there are rare problems like allergic reactions, myocarditis, and other things, but they're very, very uncommon compared to what can happen if you get the disease. So
yeah, and there is a study. I'm sorry.
Go ahead. Dr.
There is a study that we're doing jointly with College Park and the athletes. And in that study, there's more data that will be coming out, I hope, any week now, but earlier, there was a 2% finding of myocarditis using cardiac MRI, the most sensitive way you could pick this up. A third of those people were symptomatic of their COVID, 2/3 were not, of their myocarditis, 2/3 were not. So it's a very subtle disease in those who get COVID. I'm talking about the COVID induced infections, not the vaccine-induced myocarditis.
Yeah, and one of the things that has happened with COVID is so many things that normally we're studying or we're reviewing never make it to the news, or we don't have virtual face-to-faces and talk about it because it's not in the news. But all of these things that I'm reporting and telling people about, they're all publicly available. So, if you go and look, all that myocarditis data is presented to the Advisory Committee on Immunization Practices for the CDC, and it was just updated a few weeks ago. So if you just Google that, you can see the slides, and it'll show you exactly how many cases, how it compares to the baseline rate, the two vaccines compared to each other across the different ages. There's multiple means to evaluate these things. So there's something called VSD and VAERS, and all of those data are publicly available for anyone to review. And then you can see the numbers for yourself. So I think what we found out now is we think it is a real association among young adults, not over all ages, but young adults and probably teenagers, but quite rare.
Alex, we better move on to some other
Okay.
questions.
There's a lot of talk about being what it means to be immunocompromised. I defined that before the show. Someone writes, if someone is pregnant now but wasn't pregnant when she received her first 2 shots, should she be getting the 3rd shot now, or is she considered immunocompromised? Or should she wait the 8 months after the 2nd shot?
Okay.
How do you cut that one?
Yeah, so pregnancy or being postpartum, having delivered recently, we do not consider those to be immunocompromised states. Immunocompromised states are people who have had organ transplants or on chemotherapy, or they have an underlying genetic disease that leads to their immune system not working well, or they don't have a spleen, or things like that. And there's a list of the ones that are considered enough to be enough immunocompromised that you should get that 3rd shot. Pregnant women, originally what was recommended was talk with your doctor and make shared decision making. Now what's recommended by the CDC is that pregnant women should get vaccinated if they've not already been vaccinated, and if you're postpartum also get vaccinated. The vaccine now has been shown to be very safe in pregnant women. The antibodies pass to your baby, the antibodies that you make, so they go through the placenta and go to the baby and hopefully protect them in the first months of life. And we also find antibodies in the breast milk. So pregnant women are at higher risk of having more severe COVID while they're pregnant, and vaccines can protect them. So it's recommended before pregnancy, during pregnancy, after pregnancy, pregnancy should not be a reason, anything around pregnancy or pregnancy shouldn't be a reason to think that you don't want to get vaccinated.
Alex?
All right. So I know one of your colleagues at the CVD is studying the idea of mixing and matching vaccines. Justine Golden, who unfortunately does not have a mic, she wants me to read this for her. She's asking about the people who've received the Pfizer vaccine. Are they, the first 2 shots, are they the only ones who are able to get the Pfizer booster? Or can someone who got Moderna or J&J, can they get the Pfizer booster?
Yeah, that will be reviewed, and I think we will see recommendations from FDA and from CDC. That we don't have the data yet to definitively show that you can, quote, mix and match, like use a different vaccine as the boost. But sometimes even without complete data, decisions, need to be made given what proportion of the population has been vaccinated and how long it's going to take before we do have those data. So at this point, if you're immunocompetent, there is no recommendation to get a booster. So I think a lot of people, and I don't want to name names, but a lot of people are jumping the gun on booster shots. I think we should be prepared for the recommendations, but we are not quite there yet. And what I say about that, I guess I was joking, but as you may know, 2 very high-level officials at the FDA, the 2 top people who have been doing the reviews of all the COVID vaccines and have been there for 30 years, recently quit because of the thought that they were being pressured to already have a plan for boosters before the FDA, before their people had the chance to review the data. And I agree that we should be prepared, and we also should be reviewing all of that information, but we have a system, and that system should be, it's worked really well for the entire time that we've been doing this, and we should continue to trust that system. Be prepared that boosters are coming, but don't start going out and getting boosters on your own. Don't do your own mix and matching. Don't be doing any of that until we have the data and we have the recommendations.
But you know, a lot of people are asking, they're saying, well, a lot of those people who are in compromised positions, they're in that congregant care situation. They got the Moderna. So do they not get the booster, but the person in the next room, they got Pfizer, so they get a booster? I mean, what is
Well,
that going to
I guess
compromise?
that's what I'm, yeah, I understand,
Yeah.
but I guess that's what I'm saying is it's possible that the FDA and CDC will say, given how similar those vaccines are and the little bit of data that we do have on mixing them, and that the people in congregate settings may be at such high risk, then it would be worth making that recommendation. Or they may say, well, we're reviewing Pfizer right now, and the first rollout will be for anybody who got Pfizer. We expect that we're going to review Moderna in the next 3 weeks, and we're not going to make the recommendations until we have those data. So that's why I'm saying we have to wait and see, wait a bit of a time before we know that, and don't be making our own public health recommendations, because it's dangerous, because we're going on snippets, where you're going on the little bit that each of us knows. But when these data are presented, all the data that are available are presented and reviewed by experts, and that's what will allow us to make good recommendations, not like recommendations based on what you read in the New York Times.
Alex?
All right, there are several people asking about things related to stress. They're worried about what's coming. So someone writes, staff members in my office were very successful when we worked remotely on a full-time basis. With the new variants and vaccinated people getting sick, would it be possible for us to please go back to working remotely on a full-time basis for those who aren't essential workers? And Cassie, you're probably hearing a lot of those kind of questions, right? You were nodding as I was reading that.
Yeah, I would say staff, including some of my colleagues and I, and students are kind of on that same boat. I think when, like I said, some students do benefit in person, and I'm sure some staff do too. But as we've talked about, many students did so much better remotely. And I'm sure some staff and faculty also do better remotely. So I think it being an option would be most ideal. At least having that flexibility.
So what my comment would be is that, first of all, we review these things weekly with the deans and vice presidents. So none of these decisions are made in isolation. And we continue to do that on a very regular basis, as recently as yesterday. We have what we consider to be a fairly flexible teleworking policy in place, where workers can negotiate with their supervisors and work out what might work. So at the current moment in time, which means 9/9/2021, that's the position. But whenever I give a position, the answer is always subject to the next meeting, or subject to the next finding, or next piece of data, as Dr. Campbell just mentioned. So we're obviously looking at all of this. And there is also considerable flexibility in that policy at the supervisor level and at the school level. So I think we'll continue to discuss it. I wish I had a better answer for you, but we did write the policy in a pretty flexible manner.
All right, let me bring in
one other thing I might bring up, if I can, Alex. It is obviously stressful, and as you know, all of this unknown and Delta and all that is probably increasing people's stress. But a couple of things to know about and why the vaccine is so important, and that is still the vaccine is still working very well to protect people, even though there are breakthrough infection, quote, breakthroughs, meaning some vaccinated people have gotten infected. It tends to be a much milder infection. You have unvaccinated people right now are about 7 times more likely to get infected than vaccinated people. But then if you look at severe problems, depends on the study you look at, but it's 30 to 49 times more likely if you're unvaccinated to be hospitalized. And it's about 30 something times more likely that you would die if you're unvaccinated. And Alabama, you may have seen in the news about how horrible it is in some of the southern states right now, including Alabama. 94% of the people in Alabama who've died since Delta's been around were unvaccinated. So it's, it makes the news when there are people who are vaccinated and they get, not just makes the news, but makes us all worried when we see breakthrough cases, but most of them are not so severe. It's the unvaccinated people that continue to have the severe disease.
Well, it's very complicated for parents. I want to bring in Susan McKechnie, who wants to, I think, elaborate on and sort of expand this discussion because, we're back to school. It's a difficult time for parents. Susan, are you there?
I am here. Hi, Dr. Jarrell and the rest of the panel here. That I was bringing up I'm running a department and I've already had staff who have kids that have been sent home from school because they're exposed. They're quarantining everyone. And I think they're being, they're, overly cautious. These are the young kids, elementary school, they're not vaccinated. And to the extent of knowing, these are staff who need to be on campus according to the, the new rules, most of the people, most of the time. But they need to now go home. And so they're taking leave and coming back and forth. So, you kind of answered, or the question was posed that, most of the people, most of the time, can we get to maybe most of the employees some of the time, maybe kind of roll back to like the 6-1 environment where we're not 100% telework, but, I appreciate, and, definitely we know that there are sister institutions who are, everybody's 100% back. So any telework is a good thing, but it does create some work related, havoc in not knowing who's going to be here, and that additional stress does affect the work.
Yeah, Susan, first of all, I'm totally sympathetic to that. Obviously, we want flexibility to be the rule here. And so all I can say for now is what I just said a few minutes ago. However, what I will say to you is if that's happening with schools, then we're going to have to step back and look at things again and try to make what's a reasonable decision that's respectful of what parents need to be doing at home. That's really important to me. And so I guess what I want to say is I hear you.
All right, let's bring in Catherine Fornhill. Catherine, or Fornilli, I'm sorry, I read your name wrong. Catherine, are you there?
Yes,
Go ahead.
am wondering why they've relaxed the physical distancing requirements for didactic classes.
Well, let me, it sounds like this one is one I ought to address. So first of all, when we have this group of deans and vice presidents meet, we often have experts, usually have experts who come in. Dr. Cloran from Student Health, Dr. Wilbur Chen comes in often to give us advice on what's important. Dr. Campbell mentioned the Swiss cheese model a few minutes ago, saying if you overlaid certain techniques, you can lessen the chance of infection. And of course, this summer, things were looking a little better. We did keep a masking mandate in place because we felt that the data at least supported strongest that masking was an important measure to take place here and keep it on our entire campus, including our classrooms. And so at that recommendation, we felt that we were consistent with what our experts were saying, but making it so that we could still hold classes. If we had a 6-foot distancing rule, we wouldn't be able to hold didactic classes anywhere near the way we hold them today. We would have had to have multiple classrooms, which we do not. So there was certainly a decision made that we're going to rely on masking. And I think, as I mentioned earlier, with the tick up in infections, relying on KN95 masking for everyone in the classroom is an added measure here to prevent transmission. So again, on the advice of our experts at this campus, we felt that that was sufficient protection in the classroom. So that's how we've set the policy.
Okay,
Yeah, there are some data. I think all data is so fluid within COVID that it's often difficult to know. But as you probably know, there was a study in Massachusetts schools where they compared 3 and 6, and there was no difference in infection among the children who were 3 versus, required to be 3 or required to be 6. And that's why a lot of schools say no fewer than 3 feet now rather than 6 feet. And a lot of it in elementary schools has to do with you can't fit all the kids in the classrooms at the size that they are if you require 6 feet in every classroom. So you wouldn't be able to accommodate in-person schooling. But yeah, and WHO recommends a meter. So there are other data out there, and it is hard to know now with Delta if things are going to change, but yeah, so some data at least.
Cassie, you talked about the sense of isolation that people feel, and we have an anonymous question here. The person writes, am I the only person who's concerned about having now to buy KN95 masks for different environments at UMB? They're difficult to clean for reuse. They're difficult to know when they're soiled. They're expensive. It's challenging. Is the university okay with people like me having to spend $50 a month on masks? And there are probably lots of other requirements that people are facing and feeling like they're getting the heightened sense of stress. Are you hearing those sorts of things?
I thought the university was going to give them the mask, to be perfectly honest. Maybe that's just one of the schools.
Well,
that should be something we consider then.
That's just one concern that people have, that I'm seeing other comments about requirements, and people are stressing about fulfilling those requirements.
So I've been a licensed psychologist for a few years now, but I still remember grad school, and no grad student has a lot of money. Money is almost always a stressor when they come in. It's one of the reasons they tend to come to us, because we are free. So if anyone could lessen that, I know the schools have been doing a good job of creating food pantry for those who are struggling to get food. But if that is the new requirement, I think providing each student with a few masks and maybe instructions on how to better to clean them, just trying to take away as much of the barrier as possible, would help a lot. Because they already have so many things to worry about.
So the answer is we have been deeply involved in getting large quantities of KN95 masks. I can't tell you a final set of rules and procedures and processes that we're going to use. We should have those available early next week, but the answer is we're going to make them what I'm going to call freely available to large populations here at the campus. I don't want to go out on a limb and say to everybody all the time, but certainly our intention is to make masks much more, KN95 masks, much more available on this campus starting next week.
All right, I'm going to bring in, we're getting close to being out of time. A few minutes left. I'm going to, who has a question, it's a complicated question about immune status. Patty, are you there?
Yes, hi. Thank you. I had a question because actually I had a breakthrough COVID infection over the summer, and I was fully vaccinated. And so my question is, does that mean there's some immune compromised condition? Is it because it's a different variant? And then what does it mean in terms of going forward with the third vaccine? Does that change my immune system? Would it be advised to have the third vaccine, not have the third vaccine? So that's my question.
Yeah, okay, thanks, Patty. Good question. So no, we would not recommend that anybody who has breakthrough, quote, breakthrough COVID after being vaccinated, that they go to their doctor to be evaluated for immune compromise. I mean, if you have other reasons to believe that you have problems with your immune system, and this is like adding to that, then that would be reasonable. But if the only reason to believe that maybe there's something wrong with your immune system is that you have breakthrough COVID, you shouldn't do that, because there's, especially with the Delta variant, which, you know, you heard was 90-something%, it's pretty much 100%, almost every case now in the United States is Delta variant. It's more transmissible, more contagious, and so it's a little bit easier to get it. So no, it would be the same thing if you got the flu shot and then you got the flu. You wouldn't go and get an immune workup if you know, any vaccine preventable disease. So you shouldn't have to worry about your immune system if that's the only concern that you have. You know, you should talk to your doctor, of course. I don't want to give you medical advice, but and then the other question is boosters for people who have been infected. Right now, we don't know what the recommendations are going to be, but probably your infection did a little bit of boosting for you. But also, up until now, having been infected did not play any role in recommendations for primary vaccination. It will probably not play any role in booster recommendations, but we don't yet know for immunocompetent people, non-immunocompromised, what the recommendations will be, but likely it will just be silent on whether or not you've had COVID.
All right, I've got another anonymous question. Someone writes, we've been told by our supervisor and leaders in our school there is no flexibility outside of 1 day of telework per week. 1 day of telework is the only option we're given, with no room to discuss and no encouragement to talk about specific stress that it's creating for us or our specific individual circumstances. So I'm guessing it's not really a question. I'm guessing that the person is saying, you know, can we encourage more sort of understanding and flexibility?
I'm somebody who spent many hours, and I can tell you our senior staff up here spent many hours on that policy. That policy absolutely allows flexibility above 1 day a week. It has to be discussed with the supervisor and in some cases approved by the dean or the vice president of that entity. But we totally realize that people have certain circumstances that we need to accommodate. So it is not 1 day a week and done. There is flexibility in that policy to go further than that. There are obviously checks and balances in that flexibility because we also have a university to run in addition to each of us having families to manage. So there's got to be a balance between those two, but there is absolutely that flexibility in there. And I would urge you to look at that policy closely. And if you've got questions, let John Kuskar in my office know what your concern is, because we intended that to be a flexible policy. And as was pointed out, it is quite different from policies at the other universities and entities. The other thing I texted while we were talking of the other question is there will be a letter that should be coming out in the next couple of hours that will clarify things relative to the KN95 mask requirements, et cetera. So you should all be getting that very shortly. So Alex, are we out of time?
I think we are out of time. I mean, we could go on and on as people are figuring out how they're going to maneuver their way back into something like regular campus life, but I guess for another time.
Okay, well, Dr. Campbell and Dr. Moon, thank you very much. Very insightful, very useful comments. I'm sure we will be back at this topic very shortly. So thank you again. And for those in the audience, again, thank you for participating. Until the next time, see you then.
Thank you all. Thanks, Dr. Joe.